and I'm very excited to start the day by introducing Dr. Adriana Carvalhal, who will be discussing managing anxiety and polycystic kidney disease. Dr. Adriana Carvalhal is Associate Professor at the Department of Psychiatry, University of Toronto. She is also Clinical Lead and Consultation Liaison and Addiction at the Scarborough Health Network. Dr. Carvalhal has her medical and psychiatric training in Brazil, where she also completed her master's degree in science and PhD in medicine. She completed a research training at the University of Toronto with a postdoctoral research fellowship at St. Michael's in Toronto. She held several leadership positions, including head of consultation service at McMaster University, director of medical psychiatry service at St. Michael's Hospital, and psychiatrist in chief at Kingston Health Science. Dr. Carvalhal is a clinician researcher in the field of psychiatric disorders and service delivery and HIV specifically for individuals who are homeless. She has over 100 publications in medical journals and book chapters and is considered an international expert in psychiatric disorders and HIV-infected patients, where she has been invited to speak in national and international conferences in the field of psychiatry and HIV. Very, very thankful to have Dr. Carvalhal join us today. And without further ado, I'll throw to Adriana.
Thank
Dr. Carvalhal, you're just on mute. You'll have to unmute yourself.
Can you hear me now?
Yes, we can. Thank you.
Okay. So I hope we will, in the next hour, what we are going to talk is really important points related with mental health. And this interface between the physical and the mental health. And in specific, two of the most common conditions, depression and anxiety, and how can we treat those conditions. And at the same time, spend some time to talking about how can we improve our mental health and our well-being in times when this is such a relevant and important challenges we have been facing. So I thought to start this presentation talking about some important facts in mental illness in Canada. So in any given year, 1 in 5 people in Canada will experience some type of mental illness. Mental illness affects people in all ages, education, income levels, and cultures. By the age of 40, about 50% of the population in our country will have or have had a mental illness. So depression is clearly the most common and affects about 10% of the Canadian population. Anxiety also is another common condition and affect about 5% of the population and cause a mild to severe impairment in terms of the quality of life of people. Suicide accounts for about 24% of all deaths among 15 to 24 years old, and 16% of those 25 to 44 years, like in the most productive years of our lives. And mental health, mental illness is the leading cause of disability in Canada. So why is it such a high prevalence, all this mental illness? It's a very complex interplay between the genetic, the biological, personality, how we are as a person, but as well the environmental factors. And this all together explain the high prevalence of mental illness in our population. It's almost a half, about 49% of those who feel they have suffered from depression or anxiety, they never seek help. So that makes not only the prevalence is high, but unfortunately is not well recognized condition. A lot of times the stigma discrimination attached to the mental illness presents as a barrier for people not only receive the diagnosis, but also to receive the treatment, and also in terms of acceptance in their own communities. People who have a mental illness are twice as likely to have also a substance use as a problem. We know there is some of this, what we call the social determinants of health are directly related with the high prevalence of mental illness. Poverty is one of them, so 3 to 4 times more likely people in the lowest income groups have a chance to have some mental health issues. Housing as another important determinant of health, about 23 to 67% of people living in the streets, they live in the street exactly because they have a mental illness. We know lack of social support, stigma discrimination, and racism all affect and impact the mental well-being of our population. 70% of the mental illness problems have their onset or they start when in the childhood or adolescence. So a lot of research in psychiatry around recognition and the early intervention as a way to prevent the development of mental illness as an adult. We know men have a higher rates of addiction if we compare with the women. However, women have a higher rates of depression, mood disorders in general, and anxiety. A lot related women with the hormones, so plays the biological aspect I mentioned before. We know when people have a mental illness and addiction, they are more likely to die prematurely in about 10 to 20 years shorter life expectancy if we compare with the general population. So body, mind, or if you think physical and mental health are very close linked. So we know when someone has a medical condition, a chronic medical condition, they are very commonly develop some problems with the mood. Let's say chronic pain. So people who have a chronic pain are more likely to experience some mood disorder. At the same time, if someone has a mood disorder, they are more likely to develop a long-term medical condition. For example, we know depression and as an important risk factor for heart problems, for example. So if you look for kidney disease specific, this link between the physical and the mental health, we know individuals who have a chronic kidney disease, they have a higher rates of anxiety and depression comparing with the general population in about 20%. So it's a double of the general population. As I mentioned before, in Canada, the prevalence is 10% in the general population. We know depression is associated with increased risk for being in the hospital if someone has a chronic kidney disease. We also know high depressive symptoms are really associated with the high risk of the rapid clinical function decline. So for those who are, let's say, receiving hemodialysis, we know mood disorder are well-known risk factors for health and the quality of life in those individuals who have a chronic illness and require hemodialysis. For those patients who have a depression and they are receiving hemodialysis, they have a higher mortality rates if you're comparing for those who don't have any depression. When people develop depression, they are 4 times likely to withdraw from the hemodialysis treatment, exactly because of the depression. And if we think about the PKD, they have a high prevalence, people with PKD have a high prevalence of depression and anxiety, independent to be on dialysis or not. So let's spend a couple minutes talking about depression. So what exactly depression? So we know in mental health is the most common psychiatric illness. As I mentioned before, affect well-being and quality of life. Depression is more common in women. We know, as I mentioned in the previous slides, depression affects directly the course of the treatment, affect directly adherence to any treatment the person needs to take from the physical point of view. And unfortunately, people who have a depression, they also have a high rates of comorbidities. Comorbidities in medicine is when we have one, two or more conditions. And in this case, a morbidity for people who have a depression. We know there are some risk factors for people develop depression. One of them, and as I mentioned before, the personality and how we cope with the stress, it's an important risk factor. For those who tend to be a more avoidant, they avoid the problems in comparison for those individuals who have a more active coping style. Let's say I have a problem and I look for the solution. Those who have an avoidance as a coping mechanism, they have a higher risk to develop depression in comparison for people who face the problem. If someone have a past history of depression and in the course of a chronic medical illness, of course, increase the risk for the person who have a depression again. If someone has another psychiatric diagnosis, addiction comes back to the picture, we know it increases the risk for a new episode of depression. In those individuals who have a low social support, also this has increased the risk. There is even when someone, as I mentioned before, is a common condition, even as a common, unfortunately, we face different barriers in terms of recognition of the depression. One could be because the person doesn't feel comfortable to share how they are feeling. Perhaps is the fear of stigma discrimination. And I mentioned this in prior slides around the difficulties and acceptance in their own community. Often the professionals, the health professionals, they may view the depression as a normal reaction in someone who are facing so many challenges related with a medical illness. And unfortunately, often even when the professionals, they try to do a good job and try to recognize who has depression, unfortunately, some of the questions as a physician we are trained, often they are not cultural sensitive. And the fact some of the aspects of the individual culture are not taken in consideration for the recognition of and how the person is reacting, for example, to a stressful and challenging situation. There is a little difference, and I hope by the end of this talk, you guys have a clear picture. There is a difference between feel sad and feel depressed and have what we call a depression as a clinical illness. Feel sad, feel unhappy is one of the symptoms of depression, but it's not enough for us to say in psychiatry someone has a depression. We need also these symptoms to be persistent for at least 2 weeks and have a directly impact in the everyday life. So things the people was doing, the pleasure they had, they lost the pleasure. So those feelings of sadness, feel down in the dumps, has to be persistent for at least 2 weeks, and have a direct impact in the day-to-day life. We also need at least 4 of this list of symptoms to say, yes, this person has a clinical depression. So the symptoms would be changes in his sleep and appetite. Could be the person sleep more or sleep less, eat more or lost the appetite. There is this sense of fatigue and lack of energy. What come when we are assessing someone who has a medical condition could be very challenging for us to even take this symptom as a core symptom of depression, because often medical conditions make the person feel extremely tired and they have no energy. So this is often a challenge when we are assessing depression in the context of a physical health. But also the patients would explain to us that sense of worthlessness, the feeling of guilty for not be doing what they think the family or the society would expect from them. There is also some difficulties with concentration. Often the person feels agitated, restless, or getting angry easily. There is also that sense of hopelessness or helplessness. And in a more severe depression, those thoughts, life is not worth living, and even thoughts related with the suicide. So as you can see from the top to the bottom, more of those symptoms are part of the picture, more severe is a depression. So when we do the diagnosis of depression, we need to be aware not only the number of symptoms, for how long the symptoms are present and how much the symptoms affect the day-to-day life, but the severity of the symptoms. And I'm going to come back to this in a few slides when we talk about treatment. So let's move now to anxiety. Anxiety disorders is a group of several conditions, but for the sake of time and because the prevalence is more common, I thought would be important for us to speak briefly about two types of anxiety, and they are the most common. One we call generalizing anxiety disorder, and another one is called panic disorder. So generalizing anxiety disorder, or GAD, as often we say, is that sense, and this is lasts for at least 6 months, of the person be anxious and worry most of the time and most of the days for at least 6 months. Is the way the person has difficulty to control their worries. They worry about anything and everything. And besides the worry and this sense of being on the edge all the time, the person needs to have at least 3 of the following symptoms. One is feel restless, or this sense of feel in the edge. Being easily tired, because imagine this tension and the anxiety the person is experiencing for such a long period of time make them feel extremely tired. It's difficult to concentrate. Often people would say, I feel like my mind is going blank. They get angry very easily. And it's not uncommon that people would say, I cannot fall asleep because I cannot shut off the worries. And my muscles are so tense, I have a difficult to relax and fall asleep. So when we have those symptoms, for at least 6 months, we would say the person has a generalized anxiety disorder. And about 55% of the time when people have depression, they also meet the criteria for a GAD as well. So it's another very common comorbidity with depression. So then we have what we call panic attacks. And I intentionally put this why I'm showing this busy slide with a lot of symptoms, because I want to make the differentiation between panic attacks and panic disorder, okay? So panic attack, and I can say I had a panic attack one day when I had to do an MRI. It's a very common, very common situation when we have to face a very challenging situation. But doesn't mean have a panic attack, someone is gonna have a panic disorder. To say someone has a panic attack, we need at least 4 symptoms of this long list. Often people say, oh, I had a palpitation, I felt I couldn't breathe, I had a panic attack. So that's would be not a panic attack. So we need at least 4 of the symptoms. And as I mentioned from the depression, if you go down the list, you see the severity of the symptoms. The most common are the palpitation, the feeling like the heart rate increase, the sweating, the shakiness, the shortness of breath. People sometimes would describe, I feel the air is not coming in. That sense of like choking, the chest pain, often nausea or abdominal distress, dizziness, lightheaded, cold sweats. Sometimes people feel numbness in hands, a tingling sensation. That sense of derealization. That means like, I don't know where I am. I felt lost in my environment. Or that sense we call the depersonalization. I couldn't recognize who I am. Like I felt a different person. And often people would say, I felt I was losing control. I was afraid to going crazy, have a heart attack, and I felt I was gonna die in that moment. So often you don't have all the symptoms, but again, we need at least 4 to say this was a clearly panic attack. So when people have panic attacks, and that means we need more than 1 panic attack, and they come either out of the blue. Often people would say, I got up in the middle of the night and I had that panic attack. Or the panic attacks were triggered by a stressful situation, okay? So multiple panic attacks out of the blue or triggered, and at least 1 of the panic attacks by at least a month, the person is saying, I had that panic attack and I was so worried I was gonna have another one. And then I start to look for my body function. Common heart attack is the fear. I was feeling every time I was checking my pulse and I felt, I think I'm gonna have a panic attack and I think I'm gonna have a heart attack. And often the person has also the changes in the behavior related with the panic attack. A good example, imagine someone who was driving and had a panic attack. So the person feel, I am afraid if I'm gonna drive, I'm gonna have another panic attack. And it's often, and that's when we say with or without agoraphobia, the person starts to avoid those situations when they related the situation with a panic attack. For example, again, avoid to drive. Or imagine someone who were walking in the street and had a panic attack. The person progressively start to avoid to go out because they are afraid if they go out, they are going to have another panic attack. And often the person only go out or do some of those avoidant behavior when there is someone with them, because they feel at least if I have another panic attack, I will have someone to help me at that moment. So when we have this picture, we would say the person has a panic disorder. So because depression and anxiety, they are, again, so common together, I decide to talk with you about the treatment. I'm going to combine, because the treatment is very similar. And the treatment is a combination between a pharmacological treatment, medication, and a psychosocial interventions. So when we are deciding about a pharmacological treatment, and when I said before the importance of the severity of the condition, when a condition is considered a severe, and we divide in psychiatry mild, moderate, and severe. Moderate to severe condition, we would always add the medication as part of the treatment. When we have a condition as a mild, often the first line treatment is not a a pharmacological intervention is a more psychosocial intervention. We need to consider also the diagnosis and the comorbidities. The diagnosis is important because depends of if the person has only depression, the treatment, the pharmacological treatment is going to be one path. If there is depression and anxiety, we are going to consider a different path of treatment in terms of pharmacological intervention. If addiction is part of the picture, we are going to have to consider a completely different path. So it's important, when someone is facing anxiety and depression, at least have a consultation with a psychiatrist, for example, to have a clarification about the diagnosis, the comorbidities, because this is going to be a different path in terms of treatment, in terms of pharmacological treatment. We also need to be consider the physical health. And then in psychiatry, we have a specialty area of psychiatry where I work, where we call the consultation liaison. Those are the psychiatrists who treat patients who have complex medical problems, because depends of the medical problem, the pharmacological treatment is going to be completely different. So for example, some of the medications we use to treat anxiety and depression, we need to look and make sure the kidney function, what's the kidney function, is the person in dialysis or not, because it's going to make us, the decision in terms of pharmacological intervention is going to be completely different. More or less, the treatment for anxiety, depression are all going to be the medications we call antidepressants. What is the best antidepressant? What are the combinations is really based on the comorbidities, the severity, and the physical health of the individual. Then we have the second path of treatment, besides the pharmacological intervention, is what we call the psychosocial interventions. The first and the most important, and I have to say I do this for every single patient I see, is the lifestyle. And I spend a lot of time talking about physical exercise, sleep, stress reduction, diet, and how to increase activities and pleasurable activities as part of the lifestyle change. And we know, and I say to my patients, we know exercise is good for the heart, why it's not good for the brain. And we know about 30 minutes of exercise a day can reduce at least 50% of the symptoms of the depression. Not everyone buy the idea, and not everyone has often the physical strengths to engage in an exercise. But how can we work around the other lifestyle changes are so important for reduce anxiety and depression. When we talk about more formal psychotherapies, we have different modalities of psychotherapy. One, and I'm pretty sure you guys are familiar, is the cognitive behavioral therapy, or CBT. We talk about support therapy, group therapy, and one of the most new interventions with a lot of research behind in individuals who have a chronic medical illness is a mindfulness-based intervention. And we have different types of mindfulness intervention. One use the cognitive behavioral therapy as a model as well. We have the stress reduction and the acceptance and commitment therapy. Depends where the person is on dealing with the end-stage kidney disease, for example. Often we are going to use the acceptance and commitment as a type of mindfulness. If is someone who is facing, let's say, waiting in the liver transplant, or there is often someone who was very stable and there is a change in their illness, and there is increase of stress So of course, we're going to use the stress reduction as part of the model of mindfulness. We would support the person in that moment. In the next few slides, I want to share with you is about how can we cultivate the mental health and well-being. So I over the years, I became a very fan about let's improve mental health, not instead to focus so much our time in treat mental illness. So a lot of my work has been how I support my patients to cultivate this mental health and mental well-being. And I want to share this in the next few slides with you. This is what I always have in my mind as the healthy mind plater, and how things we sometimes don't appreciate as much, and we don't think often as the first thing to offer, you know, and discuss with and have this in our own life, like the sleep time, the physical activities, the capacity to focus and be in the moment and be in the present situation. And I want to mention the connected time. And I think over the last year and a half, we realized the importance of the social interaction and the social networking in the moment we lost and we had to be so isolated. So I think if there is a silver lining of this pandemic, is to bring to us the importance of all this in our lives. I'm going to share in the next few slides. Again, I mentioned about the psychotherapy mindfulness, but mindfulness is not the thing we do only when we are in therapy. It's how can we in the day-to-day, again, as a way to reduce our stress, as a way to improve our well-being, to really paying attention in the particular way. So, and we can do this in a different moments of our, even in the busy life. So I always take in the time in the morning to take my dog for a walking and pay attention, look at my environment, and really in a very focused and a purpose way, be present, not be checking my phone as I walk in the dog, but really be present and look at the environment, look at the nature. This is what we call is the basis of the mindfulness, is really paying attention in a very purpose and focused way. And why this is so helpful? So life is full of challenges, we know that. And even when the ocean is very quiet, eventually a wave is gonna come, you know? And sometimes the wave or the challenge is very big, okay? And we are not gonna be able to stop. We are not gonna be able to avoid or fight or escape of that situation. So the idea of the mindfulness, if you cannot stop the wave, learn how to surf. Is that idea of embrace the challenge. And that's, again, is the base of the acceptance and commitment mindfulness, is even when we are in a very challenging situation, how can we embrace that challenge? And to be very honest, I was so moved by some of the videos Jeff showed earlier today, and how I was reflecting how each of those life experience, the person really embrace their difficulties as a way. There was no way to fight. So let's embrace this and make the best from the situation. So this is the basis of the mindfulness. So, and again, as I mentioned before, is really be in the present moment, okay? As a human being, our tendency is either get stuck in the past or worry too much about what's coming in the future. And we completely miss the present moment. The idea of the mindfulness and is every single moment is embrace that moment. This morning when I got up, I knew I was going to have a very busy day. And I thought, you know, again, as I practice my mindfulness, to think, okay, that's going to be a very busy day. And I'm going to enjoy the fact by the end of the day, I didn't even see the day pass. So I'm going to enjoy the fact this day is going to be busy. And that's what is live in the moment. As I'm here talking to you, enjoy every moment of this unique experience for me as a clinician researcher to be talking with you. So it's really embrace this moment. And approach any experience we have with openness and curiosity and somehow a self-compassion. It's kind of, okay, I know it's going to be challenged. I have to do this blood work. Let's see what the results come. And I know I'm going to have an opportunity to speak with my doctor later about the results. You know, maybe the results are going to be good. And I was, just because I had a difficult results 3 months ago doesn't mean I'm going to have at this moment. It's really approach the situation with openness and do the best to cope with the situation and be compassionate without beat yourself up after the fact. It's also be aware of the body sensation. I always say the first thing we did when we were born and the thing we never learn how to do properly, and that's the breathing, you know. So be aware, yeah, okay, I'm facing this moment is challenge. Look at that, I start to breathe very shallow, very quick, and I'm gonna control my breathing at that moment. If I'm shaking, why I'm shaking? Again, is be aware of how the body is reacting and not just react as a default situation. Okay, so those are the elements, you know, of the mindfulness, and we know those elements are extremely helpful when people are not only facing a difficult situation, but again, how in the day-to-day we do this as a practice to help us to control and prevent the stress to take over. So that's what we do even when we have a stressful situation. And I just mentioned in the previous slide is we call stop. It's really stop. And stop means pause, you know. It's not like keep going. It's take a breath, you know. Be aware of your physical reaction. Observe, be attentive to how you are reacting. Is emotional reaction, is a physical reaction. And that's allow us to proceed with a better intention, with intention. And that moment. I love that picture in the corner. It was a colleague who shared with me, is really have faced the situation with open arms and as a way to embrace the situation. I'm going to share it, and I know Jeff told me this presentation is going to be available in a website, and I highly recommend you guys to have a look in these resources. They are all free, and they are focused in issues related with anxiety and depression. I love the mood gym. Again, we don't think a brain as a muscle we can exercise, but we exercise the brain as a way to improve anxiety and depression. I love the book about the Mindful Way Workbook. I always recommend my patients to have as an 8 weeks program to deal with the stress. So again, everyone can do in their own pace. At each of the chapter of the book, it's a 1 week program. So really, the idea to learn how to deal with the stress. And nowadays, And we have tons of apps of meditation. We didn't have a chance, perhaps in another opportunity, to talk about the meditation and things can help also deal with the stress, sleep for meditation, meditation for the sleep, since sleep is such an important aspect of prevention of stress as well. So what I hope as a take-home message is you guys go home today in your busy day-to-day lives and have and keep the idea of the complex interplay between the genetic, biological, and personality and the environmental factors, they all get together, causing what we call the mental illness. We know that the mental and physical health are very linked, and stress the stress to have a chronic illness can impact the treatment, and this can influence the psychological and medical outcomes. Individuals who have a chronic kidney disease, they have a high rates of anxiety and depression than in the general population if we compare. And the diagnosis of treatment of common psychiatric comorbidities can improve the quality of life. My last slide is my email. I want to thank you for the opportunity to speak to you. And here is my email. I would be happy to take questions now and by email after as well. Jeff, back to you.
Thank you so much, Dr. Carvalhal. That was an incredible and very timely presentation, of course, given the unprecedented times that we still find ourselves in. You covered a lot of great material as someone who was affected by mental health personally, and one that meditates on the regular. Even I had to be reminded in your presentation to watch my breath. So every time you would focus that, I would catch my shallow breaths and go deeper. And that's something that I check countless times a day. And it's something that's so important that people remember to do. We need to breathe in order to survive. And it's so second nature to people that they just go about life and don't put any thought into their breath. So I'm really glad you made that a focal point. So thank you very much for that presentation. We do have a question in the box, and I do encourage anyone, you can anonymously ask your questions as well if confidentiality is a concern. So we'll take it away and see where the conversation goes. Doctor, the very first question we have is, are there any subtle signs that could help us pick up a predisposition to mental health disease in children?
Yeah, so that's a great question, and I would like to mention a very important study about adverse child experience, or ACE. So if you Google ACE, ACE, you are going to see those important studies where they found people who have a traumatic child experience, they have more chances to develop mental illness in the future. And the idea of prevent or address those adverse child experience as a way to prevent mental illness as an adult. We know trauma as a child, again, is directly related with poor physical health as an adult. Not only the mental health increases the risk if the person had an adverse child experience, a traumatic experience as a child, but also increases the chance for people to have a poor physical health. Diabetes and heart problems are the top of the line. We know depends of the experience as a child as a different mental illness as an adult. So individuals who had, let's say, they were sexual abused as a child, they have a high chance to have post-traumatic stress disorder as an adult and a substance use disorder as an adult. Individuals who had a physical abuse as a child have a high chance, for example, to be in abusive relationships as an adult. So again, depends of the different life experience is going to shape the risk of a mental illness or even a physical illness as an adult. I highly recommend a reading about the AC studies because it's like a completely change the way we think and we approach life experience as a child in research in the clinical care.
Great, that's an excellent resource and one that we will look into and share when we promote your recording of the presentation as well, so that people can tie it together and take a look. Our next question: what inspires you to push the envelope as a healthcare provider, especially in times of COVID-19, to motivate patients to not give up?
I think in Psychiatrist is written in our DNA. Okay, I think we are used to deal with a chronic illness, right? Unfortunately, most of the severe mental illness, and an example would be bipolar disorder, schizophrenia are the most severe mental illness we have in the field. We are used to manage and follow patients for years. So I think it's written in our DNA about how we never let things to give up, right? My personal journey as a physician, I always felt very moved by again this interface between the physical and the mental health. I never imagined I would be a psychiatrist when I was in med school, but at the same time, the idea of I thought it was going to be an internal medicine physician, but the idea of how each individual reacts different to the same medical. And again, that's how I end up in psychiatry. So all this idea of, and I'm a kind of person, I don't think I give up easily. Again, I think as many of my colleagues, it's written in my DNA. So even the idea to share with my patients, the glass is not half empty, it's half full, So that's I think that's how I was moved to, in the times difficult as the pandemic, as you mentioned in the beginning, most of my research work has been in HIV, in pandemics, and a condition, who has a lot of stigma and discrimination attached, and I always say, really work in this field, even shape who I am as a person, and all the lessons I learned with my patients in the most difficult situation taught me, to never give up, even when things are so challenged.
And I think it's safe to say that if you don't have that healthcare provider that is advocating and that is positive and that is forward thinking, find a different specialist, find a different psychiatrist, find a different nephrologist. If you don't have that personal connection, or you don't feel that they are advocating as strongly on your behalf as they should be, look for options. Reach out to the foundation. We'll help connect you with someone that may be more fitted for your needs.
Yeah, and if I may add, Jeff, I didn't have an opportunity for the sake of time to talk, but the importance of when we are dealing with such a complex illness as a chronic any kidney disease, the importance of this relationship with the team and the importance of the team be very different members. I'm very
Absolutely.
lucky to work here at Scarborough and then with a nephrology team, where even in challenge times, if one of us is dropping the ball, the other one can come and help,
Right.
The importance of this multidisciplinary team, because maybe that day you have a long relationship with a nephrologist, but as a nephrologist, as a human being, it wasn't a bad day, and then you go and you talk to the social worker, or you come to talk to me, like it's the idea of, like as a family, each of us brings one important aspect of the patient's care.
Multidisciplinary care is huge. Absolutely.
Yeah, not only for this aspect of, we end up helping each other to continue to provide the best care for the patients, but also as a way to decrease the stigma, okay? So when we talk about mental illness, we know from different studies in any medical comorbidity, have also a diagnosis of mental illness increase the level of stress, the level of stigma. So the importance of the work in a multidisciplinary team. So here at Scarborough, when the patients come to the clinic, they know there is a psychiatrist there, They may gonna meet me at some point, So how the nurse practitioner, who often is the first person to see the patient, introduced this idea to the patients to say, the psychiatrist, is part of the team, and how, mental illness is so common, we're eventually going to meet her at some point.
Understood. Okay. Next question. How do you recommend a caregiver take care of themselves? They often don't want to share their needs with the patient that they're helping because they don't want to add to the patient's burden or add guilt to the mix.
Yeah, that's a great question. And I would say always, take time off. I always ask when, of course, depends of this, the situation of the patients, but when you see someone is always the same family member coming to the visit, have a question. I always ask, so how are you doing? What you are doing? Are you taking time off? Who else in the family can bring your mom or your dad to the appointment? And what do you do when you are in your time off? How often this happen? I think the time off, have a break without feeling guilty. Okay, I think that's the most important point, because you can say, I take time off, I take this afternoon, my sister takes care of my mom, but then I feel, I should be there, poor of my sister, she had to take the kids to school and didn't, it's really take the time off without the guilty,
Yes.
And it's easier to say than to do, but it's the kind of, again, using the mindfulness, it's really to be in that moment, embrace that moment, and be aware of your own feelings.
And we know if the caregiver suffers fatigue, then it all goes downhill. Then the patient isn't getting the care, then the caregiver needs care, and it's a downward spiral. So I always remind myself in that position, or remind loved ones or volunteers or advocates, that you have to take care of yourself first. It's like when in an airplane, you make sure that you put your mask on first, then you tend to the person beside you. Okay, we have a few more.
I always use the airplane as an example. Sometimes it's just make sure you have food, you eat,
Absolutely.
It's kind of simple things.
Next question. When the world is experiencing trauma, supports change, how do you motivate healthcare providers that want to do the right thing to support patients, but are tired and can't cope with their own life circumstances? How do you provide quality care without cutting corners?
Well, I think that's the moment we live here is the most, is the good example of this question, you know? And it's actually worrying me. Another day I was in the hospital and I was talking to a colleague to say, we need to be aware of the perfect storm we have now. We are all very tired, working hours, right? People are and the patients coming to the hospital are in their limits as well, you know. So the risk of the people require more of our empathy as a healthcare professional, and somehow because we are tired, we are losing the empathy, and that's the base of the medical patient relationship, is the sense of empathy. I think it's a tough question to answer, because we have been trying to remember each other, you know, and here, as many of you know, Scarborough had the highest prevalence rate in the country at one point in terms of the COVID. And again, like when I'm about in the hospital, sometimes it's just to, you know, have a light conversation with a colleague as a way to, you know, to support them and support each other. I think physicians, healthcare professionals in general are aware, and we try to remind each other, you know, yeah, to take the time off and be when we are not here, you know. The hospitals in general here at Scarborough, for sure, there is a lot of activities related with wellness. Another day I got in a nephrology floor, and they were dancing. I was caught by surprise, and the nurses say, "Hey, doctor, come to dance." So like simple things, you know, to allow the healthcare professionals to have this break. Okay. But I think we're gonna see this more challenging more and more.
Okay, thank you for that. Next question. Many of us on the line are PKD volunteers who help other patients through their troubles. How can we help ourselves not become depressed when empathizing with the often severe problems some patients have? It can be quite a burden. You, of course, deal with this issue every day.
Yeah, well, that's what I said. Like I do the mindfulness every single day. I always said after have kids, never became a good sleeper. So I do meditation before I go to bed every single day, 5-10 minutes. When I can, about twice a week, I do yoga as a way, as a physical activity to help me to relax as well. I think you mentioned the example of the airplane. That's how I always I say, you know, you cannot help anyone if you are not healthy, you know. Right. So thinking life like eat, sleep, go for a walk, those are extremely important. You need your mind empty, you know, for have this sense of empathy is so important to help help others. Again, I think in psychiatry, over the years, we learn this, you know, often, you know, even have our own therapists to help us to understand our own reactions as a way to support the patients. So again, I think have a healthy lifestyle is the way to at least to start.
Okay, thank you for that. Two last questions, and then we'll wrap up. Do you have any specific strategies for someone who is supporting a loved one who is experiencing significant depression due to chronic illness. So I mean, that is the bulk of your presentation has been that. A few key takeaways.
Yeah, I think if someone is depressed, again, make sure this person is assessed by a physician, perhaps even a psychiatrist, because it's really important, the right treatment. And as I mentioned before, 50% of people never seek help, you know?
Right.
So this is, and depression, as I hope was a take-home message, really is going to impact the outcome of the kidney illness. So it's really important, the right diagnosis and the right treatment. So I would say, talk to the physician, family physician, you know, like, and advocate for this person have a proper assessment. That would be my suggestion.
Great suggestion. Thank you. Last question. How might you encourage a loved one when they feel they don't deserve a kidney transplant? They say they aren't depressed, just looking at the data.
Yeah. Well, I probably, this person would, the patient who's going to receive the transplant is going to have, requires some support from the medical team. Again, goes back to the importance and the beauty to work in a multidisciplinary team, because most likely this person is going to need the support, probably one of the social workers involved, if there is a psychiatrist or the mental health professional in the team, to kind of probably in a few meetings, you know, to try to understand why this sense of feeling guilty, you know.
Get to the underlining.
So, yeah, I would say
problem.
this person is going to need a support through the process of the transplant.
Yeah, and the social workers, when getting worked up, are there for those concerns and matters as well.
Absolutely.
Okay, well, Dr. Carvalhal, thank you so much for the time and for your incredible presentation. Such timely information, and like I said, even being a seasoned vet myself in mental health, I need the reminders, and you've given me a number of them today to focus on. So I look forward to being in touch again, and thank you for your time today.
Thank you Jeff, for the invitation, and I hope you guys have a good rest of the day.
Thank you so much. Bye-bye.